Hello, welcome to this edition of Education Exchange. My name is Beth Berry. I am a clinical programs and customer education leader with GE HealthCare, leading today's conversation with Dr. Allison Zupon. Thanks for joining us, Dr. Zupon.
Thanks for having me. It's nice to be here. So I'm out of Kansas City, Missouri.
And Dr. Zupon is a specialist in the breast imaging realm, which as sonographers in the industry, we know has caught just wildfire of attention really the last 2 years, but from what I've seen, really the last 5 years. So the goal of today is just for Dr. Zupon and I to have an honest conversation about imaging in the breast space, about patient care, the advances in the technology, and more importantly, in the patient care that we've seen over the last several years, and that continues to evolve at a somewhat dizzying pace, I would say. I feel like every week there's a new advancement or a new something that comes out. So we'll hop right in. As I kind of alluded to, as with a lot of other specialties that we see, the imaging capabilities in the breast care space have really expanded significantly in the last decade or so. With that said, obviously every practice, like everything else, and every provider seem to have their own kind of preference for the pathway of imaging when we talk about patients within their care. Can you give us a little bit of insight into how you handle your patient care kind of pathway in your practice?
Well, first of all, as you mentioned, we are breast specialists. So we are fellowship trained in breast imaging as radiologists. So this is our passion. This is what we do day in, day out. We have been offering supplemental screening, which is an additional modality of screening on top of mammogram since 2014. That's when we first introduced automated breast ultrasound and tomosynthesis at the same time, actually. But we read everything live, which means a patient comes in for her screening exam. And then if there's an area that I'm not sure about, I'll do the diagnostic workup right then. It also means that if a patient comes in with dense breast tissue, we know that dense breast tissue makes breast cancer harder to find, and it also increases your risk. It is an independent risk factor, meaning just the fact that you have dense breasts means you have more lottery tickets for a lottery you do not want to win, because that's where breast cancer forms. It doesn't form in the fat. So since we brought in ABUS, we have been informing women of their breast density and offering them, hey, here's an additional screening tool that we can do that uses sound waves, so it's no extra radiation. It helps us pick up those cancers that can hide in dense breast tissue. So the pathway that we do is I see the mammogram, assess the density, and then my assistant will offer the patient automated breast ultrasound if she qualifies for it. And we offer an estimation of what that cost will be, because I think that's a really important part of supplemental screening is what's the cost to the patient, for adoption and also practice flow. Then my assistant tells the patient, and if the patient qualifies for a higher level of screening, so if she has intermediate risk or above 20%, which is considered a high lifetime risk, then we actually recommend contrast imaging, either with MRI or contrast enhanced mammography, which they're more involved. They involve an IV in contrast, but they also are the most sensitive, so they find the most cancers.
Yeah. One thing you kind of alluded to, right? Dense breasts. And I feel like, again, since legislative measures have been introduced, this is something that we see more and more just on the common news that we didn't before. But I think the understanding, right? We hear dense breast and mammo don't mix, but I don't know that there's that understanding. Can you go into a little bit why mammo isn't always gold standard with dense breast? Because that kind of contradicts what women have heard for generations.
Well, it still is the gold standard. It's still what we start with, because that's what we have over 4 decades of research on. And introducing screening mammography has helped us lower the mortality for breast cancer by 40% over the last 40 years. So that's an enormous improvement in breast cancer mortality. Mammograms will still find certain types of cancer that may not show up on ultrasound, specifically calcifications that can form with cancer. And that's one thing that we look for. Also asymmetries on either side and comparing year to year. So we still do recommend mammogram first. However, I am looking for breast cancers that are under a centimeter. That's my goal, is to find tiny breast cancers that a patient can't feel. And in a dense breast, the sensitivity of mammography falls. It might be 95%, meaning I'll find 95% of cancers in a fatty breast or even more. And then scattered is still above 90. And once you get to heterogeneously dense, which is where 50 to 75% of the breast is made up of that dense white tissue, then we're dropping down to in the 70s. And it might even be 60s or 50% for those with extremely dense breast tissue, where more than 75% of the breast is that white dense tissue.
Yeah.
So when you know that the sensitivity is dropping, it doesn't mean that there aren't any ways that cancers will show up on a mammogram, but it certainly means that it's not going to find as many, especially those small masses. So when you add on ultrasound, what that does is it brings the cancer detection rate for those dense breast women and heterogeneously dense women. It brings them back to the number of cancers that we can find in the scattered. So like it closes that gap. There is a detection gap when you have dense breast tissue and what mammography can do. I tell patients all the time, cancer shows up white, and so does this dense glandular tissue. It's because of how mammograms work. They're x-rays and they're showing me something in your breast that's blocking that x-ray. Well, dense tissue and cancer can block the x-ray. So it's like finding a snowball in a blizzard. That's what it can be like sometimes. And I'm trying to find tiny little things. When we add the ultrasound, it's a different way of looking through that tissue with sound beams. And that shows me those little small masses that I can't find on the mammogram. And there are times when I mean, most of the time when I see a mass on the automated breast ultrasound, I go back and look at the mammogram and I just can't find it. Even knowing that it's there, I can't find where it is on the mammogram. And I think that really speaks to how much we need ultrasound in conjunction with mammogram.
Yeah. So a little bit on the automated breast. We kind of highlighted that is a feature in your practice, as you said, and it's gaining traction. So for those that don't understand, automated breast is an automated acquisition. It's a panel acquisition through the breast tissue, much like a mammo would be, but rather than using the X-ray technology, it's using the ultrasound technology, and then it's allowing that cross-sectional review through that breast tissue. But it's also still showing a lot of the same artifacts, correct? Like the through transmission versus the shadowing to help with some of that decisive manner that you as a physician look for. Okay.
The automation, I find it superior for screening. And also we use it a lot for diagnostic imaging for a couple of reasons. Probably the first is that it covers the entire breast, and then I'm able to review the entire breast. I'm not dependent on a sonographer taking 5 pictures of each breast and then me letting it go. It is so labor intensive to do a handheld bilateral ultrasound. I don't know who's getting out of one of those in under 30 minutes for sure. It takes us about 45. And it depends on the breast size, but an automated breast ultrasound takes about 20 minutes, no matter how large your breasts are, 20 to 25. It's such, and in a time of resource scarcity where it's hard to get mammogram and ultrasound appointments in the first place, being able to move patients through quickly with a consistent quality image it improves access, and therefore it improves equity in our healthcare delivery. So I also like automated breast ultrasound because it gives me 2 views. I look at a coronal view, as you mentioned, it's more of like a cross-sectional view. It adds a view where I could spot cancer. And you read both of those views, so you get an extra look. Otherwise, the transverse images that you get with an automated ultrasound look just like a handheld ultrasound. So that's very comfortable for physicians to read because we've been reading that forever. I also really like that I have year-to-year comparison. So we've been doing it for 11 years now, and multiple times today, as I was reading images, I would see an area that had some of that artifactual shadowing, but I wasn't sure it was artifactual shadowing, and I could just look at last year's and see, oh, that's been there. or a
Yeah.
hypoechoic mass that maybe I see today on the mammogram because she's a little bit less dense or she's positioned a little bit differently. I can go back to the ABUS and realize, oh, that's a cyst that's been there for several years and we don't have to worry about it. So it gives everybody who reads mammogram knows that having a prior mammogram is a huge advantage to whether or not you call something back or whether or not you pick up cancer, and having prior ABUS is the same.
Yeah, and I did handheld, and to your point, it takes forever. And for
Mhm.
me, it was nerve-wracking. Like, does my 12 o'clock truly overlap my 1 o'clock? Does my 1 o'clock overlap my 2 o'clock? And to the point, we're getting radial and anteradial, we're not getting coronal. And I think, when I started to really dive into breast ultrasound and realizing where spiculations grow, correct me if I'm wrong, first in the C plane, which is the coronal plane, that's terrifying that, and I'm not saying 2D handheld doesn't have value. It 1,000% has value. But the fact that that ABUS would have that advantage of the coronal view and that additional look at the boundaries, to me, on top of being ultrasound technology in the coronal plane, hugely advantageous to those early catches.
Mm-hmm. And I mentioned that we use it for diagnostic purposes. And
Yeah.
I've been able to avoid stereotactic biopsies, which have a bigger needle, it's more tissue trauma, bigger risk of bleeding. I've been able to avoid those by finding that just the little tiny distortion on the coronal image on the automated breast ultrasound. It's just an extra piece of information. It takes less time to do than a handheld, and it gives me more information. So
Yeah.
I use it for screening and diagnostic all the time.
Do you still use handheld though? Do you
Oh
still
yeah.
have a place for
Yeah,
handheld in your
we
clinic?
still, because I mean every patient is different. Some patients' body habitus does not allow you to get a good picture on it. If they have kind of pectus carinatum, a protruding chest, or they're very thin, or
Mhm.
they have implants with minimal tissue over it. We do screening ABUS on patients with implants, but if they have barely any tissue around it, I'm not going to get a great picture. So, and people with pacemakers or people with ports, people with
Yeah.
cardiac monitoring devices, those we still use handheld ultrasound on that.
Okay. Um, we talked a little bit about risk, right? You mentioned the risk with dense breast. Are there other risk factors that are, kind of those immediate red flags for you that would immediately elevate a woman past, that kind of low risk category?
Um, something that's outside of the risk of the traditional risk scores, such as tyrocusic right now, but AI is starting to develop, and I know we're going to get into AI later, but the complexity of a patient's parenchymal pattern, meaning
Okay.
all density is not created equal. Just
Right.
imagine like some of these puzzles are very simple, straightforward, and some of them are overlapping little masses or just looks like asymmetries and distortions everywhere. And that complexity can increase risk, both for me not being able to see a mass, but also can increase your risk for breast cancer. So that would push me to tell somebody, you're dense, but also your particular pattern is very difficult for me to read as a human computer looking at this. I feel like I am that sometimes. Also, family history.
Hmm.
Now that's typically put into the risk assessment. Our facility, we use Tyrocusic version 8.
Okay.
And that takes into account secondary relatives and also your density. So that does account for some of these more like extended family relatives, but not everybody is using that skill. So, it's more than just your first degree relative. It's
Yeah.
also extended family. So that could put you at a higher risk.
Okay. So we've also alluded to legislation, right? For those of us, or for those of these sonographers not in the industry that, may have not heard, significant legislation came out last fall. It's not the end all be all. Obviously, there's still information that, and gaps that need to be filled with it. But I know your practice was ahead of this legislation. But what did your practice do in light of this legislation? And for those that don't know, the legislation was dense breast awareness. So women are required to be notified if they do have dense breast. Unfortunately, that's where it stops right now. I personally, knowing you, know that that's not where you stop. But what do you see, or what did you see, you and your partner see as necessary changes as this information, both peer review education that's come out, but then that pressed that legislation forward. How did you guys all adjust and evolve with this?
Well, we didn't have to do a lot of adjusting because, as you said, it was already baked into our practice. We've known for a long time that density has a mass effect. And then more recently, we learned that it is an actual independent risk factor. So we had to, there's specific legal language, and a lot of what doctors and specifically radiologists do has a particular language. And that allows us to stratify and describe our findings based on research, data proven, kind of how to say it. Like, there are certain findings that if you use these words, it puts your suspicion category a little bit higher. And it gives you a roadmap of what the standard of care is to do to manage that. And then it also provides this standardized language to communicate to our referring providers and each other. How suspicious was Dr. Zupon on this? Where exactly did she see it? What findings did she want me to follow up on? Or what findings does she want me to further evaluate when I do a diagnostic? So that also translates to this new language with density. So we had to make sure that our language matched the national standard. That having been said, nothing else really that we did changed. I think for doctors across the United States who are now getting this, that maybe weren't connected with a practice like ours, the relevant questions that they will have is, well, what does that mean that they're dense? And then what can we do about it? And it's pretty hard to tell women that you have dense tissue and we might not be able to see cancer and then not have anything to do. Not if you're gonna say that, then I think you should have supplemental screening available. Otherwise, you might actually lose trust in mammography. And I still want everybody, even with dense breasts, to get a yearly mammogram. That's the best way I have to find cancer. But also, you should qualify for additional screening. I think where it needs to go, though, and what is in it has been introduced a couple of years ago, but we're still just waiting for it to gain traction and be passed, is the Find It Early Act. And that would mandate payment, because the biggest hurdle to supplemental screening in my practice is payment. And it is more and more it's covered, and Missouri has a mandated coverage law that supplemental screening has to be covered. But because it's a state law, there's an exemption for the high risk or high deductible insurance plans.
Okay.
So it has to be a federal law to mandate that coverage. Otherwise, we are still stuck with this patchwork. Some insurances are denying it, even though they're not supposed to. And some insurances get to deny it because the patient has a high deductible. And a lot of us have high deductibles. So that's where legislation needs to be. We recognize that this will help find cancer earlier, decrease the cost of treatment, and save lives. So why isn't it covered? It will save the company's money, if you find things early and you don't have nearly the treatment costs.
Yeah, the early intervention, both
right.
quality of life, but also financial quality.
Absolutely. Smaller surgery, fewer patients need chemotherapy. You've got them now you have them into like the higher risk, so we know who to monitor. That's the part that is really holding us up.
I feel like on my end, that's where a lot of my conversations stop. We know what is best case practice, what is, and I think being on this end of it, you and I have talked about this before too. We are very privileged in our information base, but being able to transfer that over, number one, is a hurdle. But then that second hurdle is, but it's not paid for, but it's not covered. Knowing what's best and knowing what our technology can do, but not being able to always put them in that category, for me as a clinician, was incredibly frustrating. Back a little bit to kind of the balance or the introduction of ABIS. When you guys did bring it in, how did you kind of bridge that conversation with your customers or with your, I shouldn't say customers, with your patients? When you bridge that, that, okay, you only need a mammo, right? They've been told for years, you need a mammo every year. But now you're telling them they need an ultrasound and either an automated or a handheld. How do you have that conversation with that patient without sending them into kind of, I don't want to say hysteria because it's, it's scary, rightly so. How do you manage as a clinician that conversation with information, but also settling kind of some anxiety without totally kind of, not saying it's not scary because it kind of still is.
The way that I have the conversation is I tell patients, first of all, they've already had their mammogram. So I'll say, your mammogram looks normal. I don't see any change from last year. And then I would say, you do have dense breast tissue, which means that there might be small cancers that I can't see on the mammogram, and it puts you at higher risk. And then I tell the patients, I try to use facts that are digestible. So I'll say the national standard for finding cancer is like a radiologist such as myself should be able to find 3 to 6 cancers per 1,000 women, 1,000 patients that come in. And in women with denser breasts, heterogeneously dense or dense, that's closer to 3 or fewer. So adding the automated breast ultrasound helps me find 2 or 3 more cancers per 1,000 and helps get you back up to that screening. And I say it's still very unlikely that you have breast cancer. However, I'm not necessarily getting the whole story on mammogram. And
I
if
just
we
want more
do,
information.
yeah, I
Yeah.
love to have more information by doing an ultrasound.
Yeah.
I tell them it helps me find the small cancers that can hide on a mammogram. So I use the word small. I use the word early. I use the word probably not cancer. I try multiple times to keep that brain calm in the patient because it's sometimes even just me showing up and they're like, she's here.
It's funny you jolted that. I have my bachelor's degree was in psychology before I went on to X-ray and ultrasound. And I tell people all the time, I use my psychology degree 1,000 times more every day than I ever do my ultrasound degree. And it's rightly so, right? It's human nature. It's that decades old, you just get your mammo every year, but then when they call you back, there's that spidey sense that, there's something wrong and occasionally there is, but I think it's that yearning for more information. And that's what I've seen the last couple of years that I've really been, I don't want to say impressed with, but that's really caught my attention is the amount of effort upon information, right? Understanding that dense doesn't always equal cancer, but dense can equal cancer. I feel like that's really changed. And unfortunately I've been out of the immediate clinic, but I feel like the sonographers that I see and the stories that I hear, that's really where their patient base is after, is that increased information. And when they are interested in ultrasound, it's for that information. Are you seeing kind of the same trend? I know you were significantly ahead of where this message and media came from in your practice, but in the last 3 to 5 years, is that what you guys are seeing as well?
I think women in general are really good about sharing information and their experiences. So that translates. And most women who come in for a screening mammogram know somebody who's had breast cancer.
Yeah.
As women talk more and have the language, because they didn't have the language, they just were kind of kept in the dark about whether they're dense or not. And so women like Joanna Pushkin with densebreastinfo.org and Katie Couric, who had her breast cancer found by an ultrasound. And Jenna Fisher from The Office also had hers found by screening ultrasound. So as they are sharing their stories that I was told I had a normal mammogram and I didn't know that this mattered, then I think that that's created more of like a cultural awareness among women getting mammograms that, hey, even if you have a normal mammogram, it might not be the whole story. And they, for the most part, I don't see that women are afraid when we tell them you have dense breast tissue and here's what we can do. And that's probably the majority of that's because we say, here's what we can do, and we can do it today. And it's not that expensive, and it's no radiation, it's pretty quick, and there you go. we can get you back to what your mammogram would have found.
Yeah. And it really is, the story of ultrasound is convenience, right? Like it's small, it's mobile, and DBS probably isn't as mobile as I would say a lot of other modalities are, but it's more comfortable, from my experience, it's more comfortable. It's not, necessarily a day at like, a spa poolside that I like to do every day.
Right.
But the reality is, it's there, and it's the ease of access that the ultrasound market has boomed into the last 2 or 3 years, that I don't have to wait for those results, and the fact that you can, I assume, read it on the spot as well, gives you that ability to also have the patient care, not just the read, but the patient care.
Right. Yes. It's hard to separate what we do with supplemental screening with how we do it and how we give results live, same day. If you have something suspicious, I will come in and talk to you in person and explain what I see, explain my level of suspicion, which is really important because there's everywhere, anything above a 2% risk of being a malignancy, based on that data and that language I described earlier, anything above a 2% is recommended for a biopsy. Yeah. It's a BI-RADS 4, or 5 if it's above 95% risk. So that's 2.1% to 100%. That's an enormous range of how suspicious we are. So being able to have that face-to-face patient care and explain it, I know that it is a big reason for why so many women will do an ABUS in my office. Mm-hmm. They will get the results. They will have somebody to talk to. It feels like I would hope that they feel like they're more in control and they have more information and tools. So that really decreases the anxiety. I mean, mammography gets kind of dinged a lot because of the anxiety. That's listed as one of the risks, which seems silly to me. I mean, anxiety as a risk, as a reason to not screen for cancer. Do we ever say that about a colonoscopy? And that, I mean, guarantee you that's way worse than getting a mammogram. So it's there. I'm not saying that it isn't a very real part of why women maybe avoid mammograms. I'm just saying when you communicate clearly and effectively, then that anxiety is very much decreased, and women can take charge of their care and they will come back.
Yeah, absolutely. So we highlighted it a little bit, but we'll hop into AI. AI is everywhere. I mean, it is literal every aspect of our life. And healthcare is not immune, and ultrasound isn't immune, and physician practice isn't immune. With AI technologies kind of heavily now emerging into the healthcare space, how is your practice embracing and utilizing what AI has to offer in your patient care and diagnostic pathways?
Well, I was just at the Society of Breast Imaging meeting in Colorado Springs, and AI was an enormous part of the conference this year, and rightly so. It was awesome. It was so exciting. Sometimes physicians, especially radiologists, worry about AI taking our jobs, but that's not what we're dealing with right now. There is a shortage of breast radiologists. So there is a shortage of specialists giving care to women across the United States. All right, well, what does that mean? That means that fewer women can get in for their diagnostic, like just baseline. I should even back up. Fewer women have a fellowship trained breast radiologist reading their mammogram. And why does that matter? Well, do you want somebody who's been reading knees and hips all day? Oh, I need to do my 10 screeners for the day. Or do you want somebody who has read all day, every day? I've read mammograms. The mammograms it's pattern recognition, it's experience, it's knowing what to call back for sure, but also what to let go so that you're not putting women unnecessarily through this sometimes expensive and time consuming and scary workup. So your recall rate, if you are a fellowship trained rad versus if you're a generalist, I mean, I just believe it's better care. And data backs that up. So there aren't as many of us as we need. And that it particularly affects rural areas. I'm from Missouri. I'm from a rural area in Missouri, and I want my friends and family that I grew up with to get quality care. So having AI there as a second reader or a first reader, in conjunction when you're reading a mammogram, can definitely help people who are covering these large areas where they might be the only person reading there, but it can help women across the United States get a more standardized, better level of care. As a radiologist reading, even though I'm fellowship trained, AI is still going to help me because it is another look. It is a little bit more accurate than us. At least for screening, it's going to be a little more sensitive, meaning that it's going to catch things that maybe wouldn't necessarily catch my eye, but AI will be able to be trained on so many more mammograms than I can read in my lifetime. So it does help me. I think something it'll really help with too is low case scores. So the current system that I use for AI assigns a case score to a mammogram. If that case score is under 10%, I mean, that mammogram doesn't have cancer on it. I'm not going to find it either if the AI gives it a score that low. So even in places where you don't have same day reads like you do at my office, I can see where in the future you could have a fairly instant AI read on it, and if you're negative, then you get that as a preliminary result, and that would decrease the number of women who leave a facility without results. Just that could help. That could help with the anxiety. That could help with the report turnaround time. So it will make us faster, make us more accurate. Help patients.
Yeah. The way I always like to explain it, I also grew up in the Midwest, as you know, tiny town. The way I like to explain it is how many times as a clinical sonographer did I walk out and say, I don't know what this is, but I need someone else to look at this, and have someone else look at it, whether that was a fellow sonographer or a radiologist or whoever it may be, have a second set of eyes on that. And AI is not just a second set of eyes, it's sometimes 400,000 second sets of eyes of data that's been loaded. So it's not taking away your power as a clinician, as a radiologist. It's adding that additional view because, despite everything else in place, physicians are humans, sonographers are humans, everyone's human. And so it's just adding that second look times, a couple 100,000. And then on the sonographer end of it, on the practitioner side of it, it's allowing us, to your point, to do more with less. There is a critical staffing shortage of every variety of healthcare professional. That is not going to get resolved anytime soon. And when you're talking 45 minutes for an ultrasound, we literally just don't have that time. And so are there advantages within AI that we can do more, still as accurate, if not more accurate, but with less?
Yes, I would say yes. Yeah. And so AI it's by nature, it needs to be very sensitive. Yeah. You would never want AI to miss a cancer, right? I would rather it be too sensitive. And then I look and I can dismiss, okay, it marked a tissue marker from a previous benign biopsy as a 90% risk score because it looks like a calc. All right, I can dismiss that. I can do that pretty well. I think most rads can look at what the AI is marked and say that's an overcall. So we want it to be sensitive. And then, yes, then we take a second look at the spots that they found. And it does make us more confident in our reads too. So if we're talking about just the fatigue at the end of the day, when you've been in the chair reading over and over and over, knowing that you've got this backup is also really helpful.
Yeah.
And I've been mostly talking about mammo AI, but AI for ultrasound, specifically automated, there are a couple types. There's AI that will just detect, and then there's AI that will help with decision making. So depending on your level of skill in breast imaging, you might prefer one or the other or both, just to help you be able to call fewer women back. I mean, we also have to talk about how AI can help us distribute resources.
Yeah.
Yes. Physicians, sonographers, but also the callback rate.
Mm-hmm.
Nobody likes the fact that we call 10% of mammograms back, and very few of them have breast cancer. And that's a national standard again, around 10% for your callback rate. And then your CDRs, your cancer detection rate, is 3 to 6 per thousand. So, of course, we're calling a lot of women back that do not have breast cancer. So if AI can help us reduce that, that will reduce the cost, and that will reduce the number of women who have to come back for diagnostic MAM. Some places have a diagnostic MAM wait of a month or 6 weeks or more. And we know that if there's a time from screening to tissue diagnosis of more than 6 weeks, that negatively impacts a patient's life expectancy. So yeah, something
I did. Yeah, that's
I just learned, I just saw the data this week. It's something that we suspected, but
yeah.
to have the actual data, and knowing that there's definitely a wait longer than that out
Yeah.
in the country. So it will help us make better use of our resources and decrease the cost of healthcare overall. So
So
I think
you
it's fantastic.
Yeah, no, and to kind of combine a couple of the things that we've talked about, right? When we're talking about rural practice, we're not sitting here talking that they aren't qualified, but also I can't imagine going from MSK to a liver to a kidney to a ped to a breast and
Mhm.
then repeating it as a sonographer, let alone a physician. And when we talk about, you talked a little bit about patterns and scattered patterns earlier. We're looking for cancers as you highlighted less than 1 centimeter.
Right.
A lot of times 0.7, 0.8, even smaller is what we're truly hoping to target. And if your eyes are not keyed into that, right?
Right.
Even if you're on your 18th breast of the day, we are in fact human. And so I feel like adding in kind of these backstops
Mhm.
to, again, number one, eliminate with this new data, eliminate that 6 weeks, because that's true. But then we talk about callbacks, and there's, several things that factor into this. Number one, can the patient come back when we're talking rural? They're not, that's not a 5-minute jaunt down the road. Sometimes that's an hour, 2 hour, 3 hour drive.
It's an equity issue.
Yeah. And then, when we're talking about those callbacks for those, who are comfortable or not comfortable in ultrasound, that's that BI-RADS 3 to 4 category. And as a physician, not wanting to miss things, you inherently are elevating to the 4. And that's where the biopsies are coming from. And frankly, from a patient, if I have to take a needle to make sure I'm okay, I'm probably going to do it.
Mhm.
But to your point, is there a way to bring that back down
Yeah.
safely into the 3 and into the monitor
Mhm.
stage?
Mhm. Yes, I think there's a role for that. We have national benchmarks for everything. So you also have a percentage of cases that you should be calling that over which you shouldn't be calling BI-RADS 3. You can't give everything a BI-RADS 3 and follow it up in 6 months. It doesn't need to be. It's going to waste money and time. So you in my experience, and I need to say that I have a lot of respect for general radiologists who are reading a lot of things, especially out in rural areas. There is so much to keep up with
Yeah.
as far as continuing medical education and expertise in these. Even since I was in residency, the number of scans has increased, the number of protocols and sequences and what we can see as the imaging and technology improves. We are learning every organ system, every age, every disease process, every anatomic variation that is normal or isn't normal. So it's a ton to keep up with. It's just, for me, it was too much to keep up with. That's why I like to really be a
Okay.
master of breast
Yeah.
imaging. But that's just not possible for everybody. So no, having the AI give the physician that extra confidence to downgrade a lesion to either from a 4 to a 3 or a 3 to a 2
Mhm.
is going to be a tremendous help to women. And you also, as a physician, when you're explaining to a patient why you think you can follow it, you need to have that confidence. They'll read it and you go, we can probably follow this. I mean, who's going to say, sure?
Next, please.
Yeah, they're like, get out of here. I want
Yeah.
somebody who knows what they're doing.
Yeah. And what I come across, obviously not with you because I've worked with you quite a bit, but you know, and when we're talking even just breast care, right? A mammo is a very different image and a very different read than ultrasound. And so we have a bank of physicians who just purely aren't comfortable on ultrasound, and rightly so. It is, it's a wildly different image. But when we take into account then also sonographers who aren't as comfortable breast imaging, and to your point, all the tissue densities that go with it, a conversation when I, get enlisted to talk breast ultrasound, the first half of my lecture is always how breast changes and what breast tissue is, and how mine to yours is different, but also yours to yours is different, pending how old you are and what what your body and your hormones are going for. And so to your point, when you're already not 100% confident on ultrasound, and then to change, add in all of this change that can happen, it can be a little intimidating.
There's a wide variety of normal.
Yeah.
And whereas with the liver, when you do an abdominal scan,
liver's a liver.
There is the liver. That is the liver. It's the liver. Is there a mass in the liver? Well, there it is. I mean, you found it. Like, I needed to find the liver, and I found the liver. When you're doing a breast, say you're doing a targeted ultrasound after something that I found on mammogram, it may or may not be there. It looks a lot like everything else in the breast, probably. It might be an artifact. It might not be real. Also, I could tell you that it's at 10 o'clock, 5 centimeters from the nipple, but that patient has been stretched and compressed, and she might lay down and it's at
not anywhere on that side of the clock,
especially depending on how big her breast is. So you don't know what you're getting into sometimes when you go ultrasound, and then you come back and if the radiologist hasn't communicated well enough, I generally communicate like, I think this is going to go away. I think that this is nothing, especially if it's an automated ultrasound finding where I think maybe they just didn't compress enough on the automator, didn't get positioned well. I'll tell the sonographer going in, I think this is going to disappear. Or here, come look at this with me. And this is what it might look like. And then I want you to press a little bit harder. Or I'll tell them for a mammogram that we're going to target it. I'll give them a range of where I think it might be. And again, my level of suspicion. I think this is a 7 millimeter really suspicious finding. Don't come back until you found it versus it's probably a cyst, or, oh, the patient says she feels something. I don't see anything but glandular tissue. So it's, sometimes you're going and you're not going to see anything, the normal tissue. It's a very difficult thing. And then you have a patient who is already scared a lot of the time, and they're looking right at you as you scan, and you're supposed to be, quiet and stone faced.
Work on your poker face and not do as a sonographer, I always did like the lean in and head tilt, and they're like, what are you looking at? Like, nothing.
Start to measure things. Patients will get really nervous, and then I come in and say, she's just measuring cysts. You're fine. What about that big dark spot? That is actually great. That big black thing is awesome for me, because I know that's nothing to worry about.
That is the most scary looking, least scary thing we could possibly see. I think the other kind of hill that I see right now that I'm on the vendor side of it, and it's something that I take for granted now, is that I see every edition of ultrasound come out. So I see this pace of technology, and I am privileged enough to keep up with it. But being back and putting yourself back in the clinical end, when you're not getting equipment, but every 5 years, the sensitive to what you brought up to start this conversation, the sensitivity and specificity jumps wildly, right? The detail that we can see jumps wildly in that time span. So what kind of advice would you have both to physicians and to sonographers in that kind of readjustment period? Would you agree that it jumps and it's a relearning period? And how have you and your practice managed that relearning to what's normal to see and what's not normal to see? Because that does change as technology advances.
Well, when we add Tomo, when Tomo was added, and everybody's recall rate jumped. Also, the cancer detection rate that first year was up, because you're seeing so much more. And then it's just time that you adjust to your new normal. So that's that's TOMO with mammogram. And I would say ABUS is a similar pathway in that all of a sudden you're seeing the entire breast and you have to decide what's normal and what's not normal. You have to remember it's a screening exam. Most women do not have cancer. So I tell people when I teach the how to read the ABUS courses that we are going for low-hanging fruit. We are looking for cancer, not trouble. So you can't have a callback rate of 30% on a screening exam. That's an unacceptably high callback rate for a screening exam. Now, these are asymptomatic patients, because it's screening. With the handheld ultrasound machines, though, that jump in technology, you're not seeing more, you're seeing better. So I think we've decreased our BI-RADS 4s, even the BI-RADS 3s with the improved technology. Yeah, because sonography, handheld ultrasound is usually there to find something you saw in the mammogram. So as the resolution increases, then you're better able to characterize lesions. So I've been out here since 2016, but I've been reading breast ultrasound, I don't know, 12 years. Looking even so 12 years ago when I would compare priors, which could be a couple of years before that, to what I'm seeing now, it's no wonder we were sticking needles in cysts left, right, and fibroadenomas. And you also have to rely on data that comes out as people in institutions that are bigger than mine, or have an academic department, as they continue to publish what can you let go, what do you need to act on. That helps. We're very routine oriented creatures. Breast imagers are. We've got we like our standards. We like our data that tells us what to let go. Helps us sleep at night. If I know I acted in the standard of care, it's a warm blanket, so I can go home and not think about all the cases I read that day.
Yeah. One of the conversations that I have, and this is where I always have to, not saying anything against breast radiologists, but I always have to step them back a little bit, is, 5 years ago, a cyst was a cyst if it was solid black. And so now we're seeing a little bit of debris in the cyst. And I always have to be like, okay, when you stick a needle in that, though, does water come out? And they're like, well, no. I'm like, exactly. It's antiquating the real to what is being seen in the ultrasound, because to your point, there's higher resolution, and cysts aren't black holes. They're filled with viscous stuff.
True. Yeah, but I guess I don't worry about that. I mean, press it a little bit. Is there motion?
Does it squash?
Yeah. Our sonographers will say there's mobile debris in there. I'm like, okay, I'm not going to worry about that then.
We're good. We're moving on. But it's not like that anchoring to like normal, right? Like normal is X.
Yeah.
But as you see more, and again, thank God you're anomaly, but it is that conversation that I have to have of like, let's stop and realize that we're seeing real now. You're seeing debris, you're seeing those things. And so
you have to know the anatomy of the lesion that you're looking at. So you're going from kind of a divorced path and rad, the radiology imaging and then what the pathology looks like. It's getting closer with what we can see. So you're going to see the debris and maybe a thin septation or two, but that's normal on the path. Or for a fibroadenoma, you can see that it's a hypocoag mass. You can now see the fibrous septations in it, and you can see gentle lobulations better. That's what a fibroadenoma looks like under a microscope, on the gross path. So I guess I don't see myself as having calling back more things with improved visualization on the ultrasound. Yeah, I think I do fewer cyst aspirations now than I did when I first started out. That probably is just part experience, but also I think it's the technology. I can see what a 3 millimeter cyst is a lot better than I used to be able to.
Yeah. And to your point, you're seeing breast all day, every day, right? So it's this, you're seeing this, like me, this casual kind of uptick rather than this, I see maybe 5 breasts a month.
Right. Yes.
And again, all credit to those radiologists because I do not have the attention span to do what they do.
Yeah.
And the discipline of information to keep up on it. But it's that uptick of knowledge that, we're privileged within the subspecialty to be able to stay a little closer to, that allows that kind of that easier transition, I would say maybe.
Yeah.
Yeah.
The more you see cases, the more your brain has a pathway of normal, and it's easier to make those decisions. So it doesn't wear on you as much. And the more support you can have with AI, again, the easier it is to make those clinical decisions. So you can be more efficient and more accurate.
Yeah. Yeah. In the last kind of 8 minutes here, winding down, what is your hope for breast imaging? What is your hope for, I don't want to say just women's healthcare, because I feel like there, with the uptake of information, we're also acknowledging more of, the male involvement as well in some of the disease. But what is your hope for breast care as we move forward in the industry of ultrasound, but also in the industry of healthcare?
So many thoughts. I have so many opinions on this. Access is an enormous passion of mine, because if you can debate about what is the absolute best way to image over and over, but if only 50% of your population can get access to it, or for any reason, geographic, socioeconomic limitations, cultural mistrust, all, or the research isn't applicable to populations, then what are you doing? You're just not getting your goal accomplished. The goal is to find breast cancer early. So having that improved access, education, and payment is an enormous push of mine for breast care. The second one that I would feel most passionate about is more accurate risk assessment for better personalization of breast care. We started off with mammography. Great. That was the tool that we had, and that decreased breast cancer mortality by 40%. Awesome. We don't necessarily need to do that for everybody. Like patients with a higher risk, more complex tissue, different ages. This is another area where AI will help, because I saw some really interesting research on using AI to predict your 1 or 5 year risk. So right now, we generally report people's risk as a lifetime risk. And that would be like, so if you have a 20% lifetime risk, you're considered high. And what that means is that of all the women with that risk score, 20% will get breast cancer. That doesn't mean that you have a 20%. It means of all the women with that risk
category.
Yeah. Your category, this is how many will get it. But that's a lifetime risk. So we are assessing women. It's supposed to be by age 30, but really more like 25, to see if because that's the earliest that we would do a screening intervention, such as MRI, for those women who are 25 with a high risk. But at 25, having a lifetime risk of 20%, that is not the same as saying in 5 years your risk is that high. So we really need to narrow that window for our risk assessment to say, hey, this year, do you need to have an MRI or a contrast enhanced mammogram? If we could do that, then again, we wouldn't be signing women up at 25 or 30 or 40 for a yearly expensive MRI when their risk, they might not get breast cancer until they're 70. How can we utilize AI in particular to help us be very specific with what we recommend to women? It's a better use of our resources.
Yeah.
I don't like to make doctor's appointments, so I would not like to be signed up. I'm one of those awful doctors that doesn't like to go to the doctor because it takes so long. Nobody got time for that. But when I'm having a conversation that's recommending a mammogram and then in 6 months an MRI, that's a lot to ask a woman to do for decades.
Yeah.
So I think we'd have better adherence, better cancer detection rates, and better use of resources, so lower cost for the overall screening program, and then all the downstream imaging like a diagnostic workup and ultrasound after that.
I think also for patient care, right? To be a 25-year-old and to be told you have a lifetime risk. Like
Mhm.
that just hangs over your head.
Mhm.
So to your point, and frankly, whether you're the most calm person or the most anxious person, there is always that level of what if,
Mhm.
you know, when going into an exam and going into whatever, there's that level of what if. So if we can lower that bit of anxiety for the patient too, and I don't want to say it's a life sentence, but I feel like, women that are BRCA positive, right now, it's not a matter of if, it's a matter of when. And they just live their life like that. So can we take away a little bit of that weight and be, to your point, a little bit more accurate in that target, and then advocate our resources appropriately? If they have, dense breast, does that mean they go to an MRI? Does that mean they have an ABIS? And is it every year, or do we say every 2-3 years? What is that level, to your point, of access, but also of allocation of resources, so we're not
Yes.
bogging down our system?
Right. So they don't wait 6 weeks to get
Yeah.
back in for a diagnostic. And also, maybe everything could be paid for. Maybe with what money we're spending now for screening, if we can get more accurate with who needs what, then we'd have enough money for everything to be paid for, but we would be better at finding cancer. And fewer women would have to go through the whole process of a workup.
Yeah, faster, more efficient,
Mhm.
quicker access to treatment, right? I talk with my customers all the time about, when we talk advanced technologies with ultrasound, and really all ultrasound, our goal is not necessarily just to find the answer, but to find the answer to put them on a path to treatment. Because outside of a normal, something's going to happen. We want to give as much information as possible to effectively determine what that something is going to be. And if we can put them in the right modality from the get-go, do we have a better chance, right? Do we, have a better chance of spinning those wheels more correctly, and then getting them into treatment more efficiently, so that treatment gets downgraded as well? Well, thank you so much for your time. We are at the mark. I know you're super busy, so thank you so much for your time. I enjoyed our conversation, as I always do with you, and I hope that those listening do as well, and that they take away some nuggets about breast care.
Thank you so
Thank you
much.
so much, Dr.
That's great.
Zupa.
Appreciate it.